Hello, everyone, and welcome to the Quorum Podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, I'm with CJ Malcolm. CJ is Chief of Emergency Services in Gunnison, Colorado, for the paramedic program there. Welcome to the program.
Hey, what's going on, Aebhric? How you doing, man?
Doing well. We just met you again in the medicine conference in Valletta, Malta, and I met you a year and a half before that in Gunnison. And tell the listeners about you. Who is CJ? What are you doing? And how did you get to Colorado?
Oh man, that's a I don't know. I was going to say a good story, a long story, a boring story. Could be any one of the above. Well, this is a semi-public broadcast, and I may let the cat out of the bag about who I am and how I got to become a paramedic and what landed me in Gunnison. And the God's honest truth was I was your typical California-cated kid from California going to a bachelor's program in Monterey, California. And I overdosed on drugs, specifically psilocybin. And I just need to say in honor of Nancy Reagan, don't do drugs. Anyways,
Wow.
I took psilocybin my first freshman year. I was living a high life as your typical California kid, surfing, doing all the deal, privileged. And a paramedic saved my life. And I'll never forget that paramedic. I can still see his face to this day. Now, whether he did or didn't, now knowing 30 years later, he probably just gave me a bunch of fluids and took me to the ED. His compassion saved my life, and that stuck with me and led me into paramedicine several years after that event. So that was kind of my entrance into the profession. From there, I got serious about education, and I put myself on the 7-year plan to complete a bachelor's in business admin. During that time, I was always kind of an outdoorsman and just was attracted to the wilderness. And in California, they were starting these lifeguard academies, these ocean lifeguarding academies, kind of like Baywatch, but more serious. I mean, they're like giant competitions. And you're in there with these water polo player kids, these surfers, these great swimmers, none of which I was. And I jumped into that profession as a professional lifeguard, which really was my entrance and as an EMT into kind of that pre-hospital care rescue. And it was a wonderful profession for me. For about a decade, I worked as a professional guard and became a paramedic during that time. And did the typical American medical response. That's obviously a big private organization in the U.S. And worked as an urban medic for a year or two. And that led me into, I got injured early on as a medic, doing all the lifts that we used to have pre-gurneys that were mechanical.
Yeah, the old strikers that didn't lift anything. Yep, I remember them. Yep.
I remember, Aebhric, I don't know about you, but I was thinking back to those days, and I did the math. I was doing like 60 deadlifts a day, something like that, upwards of 100 on a bad day.
Yep.
I mean, you get someone that's stroked out, balled up in a corner, you're lifting them onto the gurney, then you're lifting the gurney up, then you're lifting the gurney into the rig, lifting the gurney down, sheeting them over and over and over. And that destroyed me as a young man in my first 2 years. And I'm happy it did. I became crippled for a while there, and it turned my world upside down, how I identified myself is this young surfer, skier, climber, paramedic guy. And I learned that placing my identity in those things was really false. And it got me to shift my mind and look at myself more as a human being and what I was passionate about. And so while I was injured, and my sugar mama, my wife, Heather, who's a nurse, who was making great money, I kind of suffered on the sidelines as an injured human being, and went back to school and got my master's in organizational leadership. I fortunately healed up. I was one of the lucky few without surgery. And I kind of went back to my passion, which was always the out of doors. And I became a ranger with the National Park Service and just worked in some of the most incredible areas, from the Grand Tetons to Yellowstone. I was the winter ranger in Yellowstone. And then my last post was at Grand Canyon, running their EMS and preventive search and rescue team for a number of years before I landed in Gunnison. And really what brought me to Gunnison was I had a family, and living remotely in the Park Service was tough, but my passion was in austere medicine. Back then we called it wilderness medicine, but we know there's a difference now.
There is.
And Gunnison just had this profile, man. It's we call it an island. We're an absolute island out here. There is no one here to help us, no one here to service us. We are responsible for just this huge scope, and it's this beautiful, austere wilderness out here. And I saw this potential in this country, the way we're moving with tourism and where people want to live. And so we moved our family here, which was like actually coming to the big city, to be honest. We have 2 or 3 markets out here. It's incredible. Whereas when I was on Grand Canyon, it was a small village out there with 7 million people slamming their way through the canyon, which is a whole nother discussion. But that's how I wound up in Gunnison, and it's been just a true blessing and incredible learning for me as a person and as a dad and as a paramedic.
Well, that is a circuitous route, kind of almost full circle, medic over to law enforcement and back to medic. So you went through Galinko to become a park ranger.
Well, I thought I was going the law enforcement route, and I went through their seasonal law enforcement academy, and I got in the Tetons, and they found out I was a medic. And thank goodness, I just wasn't interested in writing tickets for people smoking weed before they went on their hikes. And it just wasn't my deal. And I ended up running their ambulance in the Tetons with actually Dr. Will Smith. He was my medical director back then. And in Yellowstone, it was Dr. Luann Freer. Do you know her?
Yes, I do. I met her ages ago.
So that just sucked me back into where I was supposed to be, which is austere medicine. So I really never pursued the law enforcement thing too much. I ended up bailing on that. And when I got to Grand Canyon is arguably at the center of just incredible wilderness, and it intersects wilderness with just unbelievable environmental and medical related illnesses that we had to deal with out there as rangers. And my job out there was to prevent morbidity and mortality in our visiting population, which was back then around 6 million people, and then to respond to it, either on foot, by boat, or by helicopter.
Yeah, it's such a variance from the top of the canyon to the bottom. It can either be cold on top, you get to the bottom, and people have heat problems, or it's the other way around. It's just a vast area, and I mean, if you're trying to cover that whole hole in the ground, gee, you got to have hundreds of park staff to do that.
Oh man, you nailed it on the head. And no, we didn't have hundreds. I had about 7 rangers that worked on my staff and about 40 volunteers. They were called PSAR Rangers, Preventive Search and Rescue, and they were EMTs, paramedics, and nurses. And our primary mission was to educate the public going into the canyon about safe hiking, because you said it's an inverted mountain. Usually we're used to going to the Alps, to the Sierras, to the Rockies, and you hike up. You get tired, you eat lunch, you take a nap if you're smart, you hike down. Grand Canyon's a different deal. You get sucked right into that bad boy. You look up and you've got 5,000 vertical feet in 120-degree heat over 10 miles, and it hammers people. And so we really were trying to prevent the inevitable SARS, of which we had hundreds. We had around 600 what we called minor SARS and about 350 major SARs. And of those, so one a day major SAR,
Wow.
and two a day minor SARs, where you're just kind of, trying to get someone to self-rescue out of the canyon. In the major SARs, we were so busy, we had to have two contracted helicopters, which my staff would staff as paramedics, and fly somewhere along the 300 river miles of the canyon and fly in there for MIs, for people that had recent ablations, and their surgeon said, "Oh yeah, you can go into this environment." For people, one of my craziest cases, I had a guy that was doing peritoneal lavage. He wanted to through hike the. I respected this guy. He wanted to get in the wilderness, and he brought his fluids with him, and obviously he got down to the bottom and had a serious electrolyte metabolic derangement. We did point of care testing. And it was just a wild experience out there, man. It was exactly what COROM is promoting and training medics around the world to address. It was so cool.
Wow. Well, so what medical evac do you have? I mean, some of those canyons are so straight, you can't get a chopper in there.
We had an MD 900, and that's one of those no tail rotor systems that looks super cool. It's got these like bumblebee colors. It's kind of famous in a lot of the like search and rescue magazines. You'll see it pop up. We had a lot of helicopter modules that we flew, and we were going out in the summertime 2-3 times a day. We would also, my staff of rangers would be stationed throughout the canyon, and they would just hike. So a lot of it's hiking. You could just be doing wheeled litters, getting people out, technical rescues. We would do what's called mule drags. And there's a string of mules going in and out of the canyon every day because there's a kind of a little city. If you ever heard of Phantom Ranch down there at the bottom?
No.
Oh, man, probably got 100+ years of history back to the time of John Muir. And it's just a ranch at the bottom of the canyon that requires trash and mail and goods to be taken in and out of there for river trippers and canyon folk that live down in there. So sometimes we put you on a mule. I put a guy on that was having a bifascicular block onto a mule to be taken out of the canyon. One time I walked a guy out with a bifascicular block before I knew the severity of that that disease process, and he made it just fine, by the way. And so there's a lot of methods that we use to extricate individuals from the canyon, and it was just a very, very busy system.
Wow, so it's a mule or a helicopter? Those are your two options.
Mule, helicopter, walk your butt out. There's actually a clinic down at the bottom of the canyon as well, which is very cool. We get residents occasionally from austere medical programs, physicians that'll go down there and work at the clinic at Phantom Ranch and just experience what it's like being a doc down there. It's a neat mission profile.
Nice. That's amazing. And then you decided to go to Gunnison. Tell us about Gunnison. How many years you've been there now? And we need to talk about Fresh Whole Blood. We need to talk about PFC and all of the push forward you've been doing at Gunnison. So tell us, how you went from the Park Service to Gunnison?
Working for the Park Service, I was a federale, and it's federal, and we just felt that as a family, we wanted to come back more to civilian life. And I was always interested in the resource of the land in Gunnison. You've been here, Aebhric. It's beautiful. It's incredible. It's this remote basin surrounded by the Rocky Mountains. And that really attracted me as a paramedic. Urban medicine has its place, and it's such a great building stone. But I fell in love with austere medicine at Grand Canyon primarily. And I just saw this potential, knowing where humanity was going, wanting to live more and more rurally in these rural villas and isolated places. And I saw potential. I mean, Gunnison almost reminded me of the Park Service, almost like the Grand Canyon. It's this giant, beautiful, harsh resource full of people that want to ski and climb and fish and hunt and do all of the great things. And so My wife and I relocated here about 8 years ago. And, just being in the right place, the right time. I started out as a captain here, and about 2 years into that, a chief slot opened up, and I took on a leadership role as a chief.
So 6 years you've been leading the emergency services there in Gunnison, and you've made profound changes. So you have brought in fresh whole blood. So you have blood on your rigs.
Yes.
And any other blood products or just fresh whole blood?
We do never frozen plasma, so fresh plasma.
Nice.
And packed red blood cells. So those two, we can bring 1, 2, or more units. Typically in the field, getting in much more than 2 units is unlikely. And obviously we bring TXA as well.
How did you do that? How did you get people on board? And there's so much kickback everywhere in the world. Here in Europe, it's mental. There's so many people who are against it. But in the States, it's a little bit more encompassing. But still, there's kickback. How did you manage that?
I don't know. It really was hard here, and it took years of discussion and looking at what is required of a lab here in the United States to be certified by the bodies that certify labs, and fights and gnashing of teeth and working together, writing papers. Interestingly, getting it through the state, through our process in California, we are beholden to a state board with a primary physician advisor and other physicians and medics. And we have to go for what's called waivers here in the state of Colorado. Every state is different. It's a decent process. So if a paramedic crew has a unique mission profile and they feel the need that they have to give a specific medication or do finger thoracostomy or something along those lines, for us blood products as well as several other things, we go through the state, and we wrote a very simple white position paper, referenced a lot of the other great systems around us, specifically in Texas. And the state was like, this is a no-brainer. They're EMS minded, no different than us. And fortunately, very common sense driven. I mean, we've learned that red stuff goes out, red stuff needs to go in. There's a lot of fantastic science behind that, but sometimes Occam's razor is really the way I think we should operate a lot of this stuff. And so the state process was easy. Going through the lab process in the blood bank was challenging. But you ask, how did we do it? I mean, the honest truth is, Aebhric, it's leadership. And we have taken leadership here and different concepts of being a learning organization very seriously. And we utilized a lot of organizational leadership and organizational behavior tools to create a solid culture, which we knew would eventually be able to push through some of these oddly controversial decisions.
It's more than just stopping by the local ER and picking up a pint of blood. There are tons of paperwork. Tons of
paperwork. But, yes, tons of paperwork, but not daunting. I mean, when something is the right thing to do, I think we all can agree that we feel empowered. Hey, we have to do this thing. And so the paperwork can become exciting. But really creating a sense of shared vision with our partner, the hospital, in our lab here, as well as others, creating that sense of buy-in, shared vision was mandatory, and it took a while.
So why is there so much hostility towards EMS blood?
In the U.S. or here in Gunnison?
I'd say in the U.S., in EMS in general.
Boy, that's a great question. I'm not totally certain, but I think if I were to guess, since you're putting me on the spot, the genesis comes from the fact that EMS I still view it as a relatively new profession. We don't have these massive nursing unions, these massive fire department unions. We don't have centuries of camaraderie or research. And EMS was really born out of World War II and primarily Vietnam, as you well know. Learning that we can stabilize people in the field and put tourniquets on and save lives and so on and so forth. And so we really only have 40, 50 years of history. And in the last 20 years, it's now recognized that EMS is a huge partner in evidence-based medicine and in research. And not everyone is there. There's still fantastic surgeons out there. I've had surgeons at the hospital just half a decade ago. I bring someone in that maybe fell off of a roof and had some kind of traumatic injury, and there was a lot of animosity why we didn't backboard them or put them on a C-collar. When we did, in some regards, immobilize them on a gurney. They were immobilized, self-splinting in a position of comfort, recognized that there could be some kind of spinal injury, but highly likely there isn't, because we don't just backboard based on mechanism anymore. There's a lot more to it. And so those are surgeons and physicians and nurses that come from a line of training and thinking that goes back 10, 20 plus years ago. They really don't have the recognition. It's not their fault. It's probably our fault. They don't have the recognition that EMS is a tremendous partner in research and evidence-based. And so when we bring up something like now we're going to give blood and the value of a blood bank and all of the energy that goes into that, they're kind of like, who are these guys? They're just going to walk into my cooler and grab some OPAs and some never frozen plasma and take it out into the field. And so there's a lack of recognition. And I think that stems from the youthfulness of our profession and the fact that we really aren't unified yet, nationally in America or even internationally. We don't have the same voice bringing in systems thinking, saying, hey, we're a part of the system and we bring in good information. We're still learning as a profession how to do that. And so there's eyebrows being raised when we want to bring blood products into the system. So part of me understands it. Part of it makes me really angry, which is I just have to go have a pint with you at it's 6 o'clock, you said, and just dump those feelings because they're really egotistical and self-motivated when I get angry. It's not fair. It's I think somewhat understandable.
Do you think that the degree paramedic would be the way forward to address this issue?
Whoa, man, that's a big question. Honestly, I go back and forth on that, but I do think yes. I'm more and more in the camp, and I've really always been in this camp, that education is a wonderful thing for humanity, a wonderful thing, especially when you get to the paramedic level. As I kind of said in my youth, I started out going for the bachelor's, I think because it was a way of life and expected of me, and I didn't know how to study and be a student. Really becoming a paramedic was one of the most challenging processes that I had to go through, and I had so much pride in that. And so when you talk about the degreed paramedic, I envision a group of individuals that have worked through that immaturity already, and they're very focused on this part of healthcare. And I think that education is the solution for a lot of problems worldwide. And so, yes, I am in support of the degreed paramedic. I've been thinking a lot about this. And I think that would help us unify as a species, as a profession, what it is we're here to contribute to the planet, to our countries, to our counties, to our cities.
There's a lot of pushback on just even an associate's degree, paramedic. There's huge pushback.
Aebhric, out here in America, a lot of the pushback is fire departments.
Yep.
The reason I think that could be is a paramedic is a great tool for fire departments. They're typically paid less. They're called single role paramedics. Apparently now there's a thing called a civilian paramedic, but it's all an excuse to pay them, yes, less, use them as slave labor for 4 to 5 years to want to get through that cash cow of EMS into a well-paying fire job where they will always have a pool of people to pull from. Now, that's kind of a nefarious interpretation of it, and obviously is not what's occurring with every fire service in our country. There's some fantastic fire services that set wonderful precedents, both in pre-hospital care and in fire safety. But I do think that this is a problem we need to work through as a profession, not using paramedics as slave labor.
I think the fire department is a big problem. And at the moment, maybe the issue is the fact that paramedics are under the Department of Transportation, when in fact they need to be under the Department of Health.
Yeah, I've been thinking a lot about that lately. Yes, I would agree with that. I've been thinking on a federal level where it fits better. There's also the U.S. Fire Service, and they have developed a new branch of paramedicine and EMS response because they've realized that 90% of their volume is EMS related. And so it makes me nervous that the U.S. Fire Administration wants to nest EMS under them, though I do respect it. I respect their leader. They have a very good leader right now that I'm learning about. And, I struggle myself do I need to have some personal acceptance or just even professional acceptance as a leader in EMS that it just is the way it is in America, and it will be nested in some areas under fire. We have to learn to accept our master at times, and other parts of me want to contest that and agree with you. No, we need to move this under the Department of Health. That's where it should go. And I'm really debating that right now in my profession where I want to advocate. I'm still in a process of learning and listening. But it's coming up quick here, Aebhric, in America, with all that's going controversial, speaking from the Elijah McClain death in Colorado to the discussion that you brought up, should paramedics be degreed? It's all coming to kind of this point where there's a lot of discussion and contention. And I think it's fantastic, honestly, for our profession that there's awareness coming at a time where, frankly, healthcare is in a state of crisis in our country. And so I want to be a part of that, and I'm open and dynamic, but
so that's a big move to get, first off, a degree, associate's degree paramedic. That's not so there's a bunch of degrees out there, but they're like leadership degrees, which nothing against yourself that you've had one of those, but that's not a clinical degree. So having so one hand grenade in the room is paramedics having a clinical degree at the master's level, at the bachelor's level. And then we need to talk about David Pfeiffer from Eastern Kentucky University that dropped the nuclear bomb on pushing for a master's level paramedic equal to a PA. How would that work within your department?
I like it. I like it. I mean, again, as I said at the beginning of this, you said, where is my stance on degreed medics? And I'm open. And we've been talking about this for years, but I haven't seriously been considering it until about the last year and a half with all the controversy I've mentioned. But, looking at the model in UK, it just makes sense what the National Health Service has done in the UK. They've created a life for these individuals, for paramedics and EMTs that are serving the public in such a wonderful way, from their bachelor's level to their master's level clinicians, either in critical care medicine or what we would call community paramedicine. Yes, I think there's a need. I think we need to move away from the model of EMS running lights and sirens to every single hangnail and every single flu-like symptoms or stitches or any of these things. where a lot of us have the years of experience, being a 20 plus year medic myself. We have the years of experience to help decompress what's occurring in our hospitals, frankly, internationally. We can decompress that in the field at a decent expense and really broaden, use our knowledge base as providers and answer to a huge need that's going on right now, and not just ship everyone to the ED is an emergency situation. That's not going to work. It's not working in our big EDs. It's not working in our small EDs. It's not working for the people getting a $5,000 bill going in there because they're legitimately afraid that their kid is really sick. And we can go to them and say, hey, let's work with you a bit. Let's stay on scene. Let's learn about their past medical history. Maybe I can get on a phone with the doc if I need to. Maybe I have the training and skills at a master's level clinician aspect like a PA to be able to problem solve this right here and now. Yes, I'm supportive. I think this is a good move.
I think just the ability to treat and release would reduce a tremendous amount of load for you.
It would. It would, and frankly, we're doing that now in our service, and there's a lot of services that do it.
Brilliant.
But yes, that a treat and release will decompress it. Our centers for Medicare and Medicaid need to get on board with this. I know they're studying the treat and release right now, but frankly, it's the government. Things move glacially slow.
So you saw a need in your department. You brought in Dr. Sean Keenan, you brought in me, you brought in a bunch of us to come in and run prolonged field care courses, the austere emergency care. So what was your, what made you do that? What problem did you see in your department that you thought that prolonged field care would address that? And then how has PFC helped you?
Here in Gunnison, we have such an extreme mission profile. I know you interviewed Captain Nick Zuber, just a fantastic individual, terribly educated, as in terribly good. And our mission profile here, it's scary, Aebhric. It can take us an hour to 2 hours to get to the extreme ends of our district, where there's a population of individuals either living in a remote community like this micro urban community, to backcountry users, to snowmobilers, to rock climbers, river runners, people just camping with their kids. And we get out to these remote regions and we can have any number of illnesses, whether it's trauma related, typically trauma, or a medical related situation. So we wanted to bring the best level of service to the population coming here, our clientele, our customers. And we believe that came in the form of austere medicine training combined with critical care paramedicine, which in the United States, if you want to be a real critical care paramedic, I've been studying this stuff 10, 15 years. It takes a long, long time. And it's very, very scary medicine to be taken seriously when you're in such a remote environment. And so tagging into groups like yourself with CoROM, with Sean Keenan, with others, and diving into the actual science of austere medicine, bringing in advanced education, looking at ultrasounds, looking at is it appropriate to snag someone's airway and RSI them when you're 2-3 hours out? I mean, you could be a day out. We have some mission profiles here where you could be stuck with the patient for a day. Bringing in responsibility and training into that decision-making process was absolutely necessary for our team here.
What clinical changes have you seen? What have you seen an improvement of clinical outcomes from this training?
That's a hard thing to measure. But what I can say is that we don't take this training lightly. You have opened our universe up to considering bringing in ultrasound, which everyone's in on ultrasound. It's the new fad on the street,
Yep.
and I don't say that disrespectfully, but is a chief in a system where we run 1,600 calls a year. Granted, one call to us is like 10 urban calls because our average length of time on scene is 1 to 5 hours.
Wow.
And so that's a tremendous amount of time in your clinical practice as a paramedic. As a chief here with low rep, high acuity patients, we take very seriously every skill we bring in, and we do not bring in another skill until we are competent. We have patients on ventilators for 4 to 6 hours at times. It's not just a quick bebop from one level 2 to another level 1 hospital with a nurse and the medic down in Denver running them to a specialist for an hour. We're with these people sometimes even longer, upwards of 12 hours, because we start the process in the field. We might take them to the ED here for some stabilization, and then we might move them on. So every skill that we bring on, next is ultrasound for us. We believe in personal mastery, and we do a lot of inward looking in the mirror here, and we hold ourselves rigorously to appropriate scrutiny when we are ready to take this on. And so you ask, do I see clinical outcomes yet? Sure. What I see is the maturing of my staff and being opened up to this very serious level of medicine that we believe will save lives out here. And we believe that we have the tools and the skills to stabilize in the field appropriately, bring them to the ED, and help save lives versus that load and go aspect where you're missing such an opportunity to intervene appropriately in a patient, identify a metabolic derangement using an EPOC or an ISTAT, or identify something that perhaps we shouldn't bring them into our clinic, into our ED, and fly them direct from scene, which is still going to take hours. For instance, I was recently in Malta with you, and we were working on measuring not ocular eye pressure, but retinal.
Yeah, ICP. Yeah, measuring the nerve sheath for ICP. Yeah.
Can we bring this to the field? We had a head injury last week with a snowmobiler in a very isolated location. We were with them for hours. And so that would have been a valuable tool up there to be able to measure that retinal width to determine ICP. It's just one more thing. When you're flying them in, we're like, hey, we measured it at, I don't know the value. Let's say it's 8 millimeters. I can't remember.
5 millimeters. Yeah.
5 millimeters. That goes to the surgeon. And he's like, whoa, they measured his retina in the field? Yeah, we did. So maybe that increases a level of severity. Maybe I can get on the line with them as the helicopter's inbound and let them know, like, this guy's got ICP. Undoubtedly scientifically proven in the field.
Ultrasound is definitely one of those things that'll be easy to implement and easily to see a change. And I'm impressed with your tenacity of you must master a skill before we give you more. I mean, there's one problem with paramedic school is we have 70 skills, clinical skills we got to learn in all at once. But I like the fact that you're like, okay, let's get this down and then move forward. And one thing we do on our APUS course, austere and pre-hospital ultrasound course, they have to do 20 EFAST before they finish the 2 days. And I've been on so many ultrasound. In fact, Monday I'm going to an ultrasound course in Italy, focusing on ultrasound for infectious disease, tropical medicine. And I like seeing how people teach. But what I've seen is like, okay, do an EFAST. Okay, you're good. No, you must master it. You must self-master before you can. Yeah, and we do this before you leave class.
I'm sorry to interrupt you, Aebhric. We take this very seriously, and just to put my money where my mouth is, our goal is to have all FPC trained paramedics. That's flight paramedic certified. that takes a tremendous amount of time. And we have a lot of people in the pipeline, and we have very strict criterion. We know here that certification does not mean qualification or competency. So with how dangerous this medicine can be in our service, sorry, there's a call going on right now. I'm getting distracted here.
No worries.
Stand by.
Gunnison EMS, please respond to the Taylor Park Trading Post. Stand by for a avalanche.
Aebhric, I'm back. Sorry about that. Case in point about our the Taylor Park Trading Post. You're welcome to put that in your podcast if you'd like.
I will. That's fantastic. An avalanche of all things. Absolutely awesome.
That's about an hour away for us. And that is potentially, who knows how long if we're going into the field with search and rescue. And it brings into the clinical decision making that my staff will have to make where they are geographically in the state. We know that a Flight for Life flight service is one of the few programs out here, I believe CareFlight does as well, where they do, they will take an individual like an avalanche victim if they become hypothermic, just based on them being so far out there, and take them to the nearest bypass center, even if they are clinically dead. We know that if they're cold and we can take them to a place where they'll do extracorporeal rewarming, my staff have to know which flight service to call to institute that protocol in the rare event that we could potentially save this poor individual's life.
That's incredible.
And so that's tough decision making. So sorry for that little sidetrack there.
No, it's perfect. I'll definitely include the call. That's awesome.
So back to us, our critical care program, we have a task book that must be completed in a specific order. And we felt recently that we were not appropriately guiding our new FPC medics through this process. And we pumped the brakes. Just in the last week, we sat down, we process mapped how to ensure that our new critical care paramedic staff are actually competent and not just running around with a patch on their shoulder that says they're flight paramedic certified and they can practice these skills. We want them competent, and that's about a 1.5 year long process to 2 year long process, entering into this environment with us. And really, it comes from a place of being honest with oneself. We take concepts from books like Good to Great. This is Jim Collins' book on leadership, and he discusses a thing called a culture of discipline. And when I first brought this up, my staff ooh, that word discipline, that's a little bit too forward. Let's not use that term. Let's use something else. I said, BS, discipline is not a negative term. I mean, it's not a disciplinary action. You use it like that, it is pejorative. No, discipline is being honest with oneself, ensure that you are truly seeking personal mastery, and we are disciplined to get those 20 ultrasounds, like you say, and have a continuing education program to ensure that perishable skill maintains. And so we take this very seriously here. And if we feel that, if I feel that our medicine is regressing, that can happen. Things are perishable. We regress our skills straight up. We take a step back. We do vent scenarios. We do RSI scenarios. Soon we'll be doing ultrasound scenarios. We talk about some of these drips and pressors that we're giving. They can be highly complicated. Given an esmolol drip and a nicardipine trip to someone that's having a AAA over the next 6 hours in a snowstorm, transporting them to the nearest level 1 hospital, that's scary stuff. Nice. And so we regress ourselves. I regress myself all the time, get back to the basics, have great individuals like you mentor me up, and get back in the game. And it starts with developing a culture of honesty. here in our system, and that's big for us.
It's really important, and it draws me from the Special Forces training on you can earn the long tab. So great, you're a Green Beret. You get to the team. You have to get those skills. So sure, you learn those skills as a flight paramedic. Great. So you have the patch, and that's great. But you need to continue to do then scenarios, and hands-on, kind of clinical-based peer review in order to be as good as you want to be. And in the Green Berets, we did this, and we're never so when I was a cop, the saying was keep shooting until you hit it. And in the Green Berets, we keep shooting until you never miss. And that's the difference. And I'm glad that you're doing this. I see your passion to make your medics the best.
Yes. And that is our drive. It's actually our hedgehog statement, which is kind of like a vision statement, which is very simply, GVHEMS is an industry leader in pre-hospital medicine, 911, interfacility transport, and all hazards response in Gunnison's role in austere Rocky Mountain region. We want to be an industry leader. Whether we are or not, we always see it as a drive going towards that. Thinking you're at the top, thinking you're like you kind of caught yourself the elite is a dangerous place to live. I prefer that we all remain comfortably uncomfortable. And we're open with one another when we are uncomfortable, and we seek help, and we slow down, and that's our drive.
Comfortably uncomfortable. I like it. So CJ, I ask a final question for all of my guests. My final question for you is this: what advice do you have for the remote paramedic, the new nurse, the new doc, who is just starting out on their career in austere medicine?
Be proud of yourself. This is a tough industry to break into, and it traditionally starts with a lot of training with little experience. And that's okay. When you finally do break in, it may not be in the form or the manner or the shape or the job that you anticipated. I thought I was destined to be a Navy SEAL. I thought I was destined to be a PJ, and you heard my story early on, how I basically obliterated that chance. Maybe fortunately, and for a lot of years when I did get into austere medicine, I didn't feel like I was a part of the club, a part of the cool PJ group, and all of these amazing guys that you've introduced me to in Norway and the fantastic medicine they're doing. And I kind of looked down on myself, and I realized something. Fortunately, at a point in my career, I was doing a combined exercise with the PJs as a Grand Canyon medic, and I was flying in one of their Chinooks to go do this super cool exercise. And I had always looked down on myself that I'd never made it as a special forces guy. And we got out to do the scenario, and it quickly dawned on me that as much as I envied their cool mission profile and skills and path they had chosen, they envied me just as much for being a ranger or a ski patroller or just an individual who has a passion for austere medicine in the way that I was getting my volume and experience.
Indeed.
And they're not lifted me up, but we're all on the same team. And we're all after the same thing, to lift this profession up and to demonstrate to the world that paramedicine is full of intelligent, degreed, doctorate, PhD level, even associates level individuals that have a contribution to decompress healthcare in this world, and have pride in that as a new person. Your entryway may not be clear, but it's there, and you're all in the team, whether you're an SF guy or gal, or you're a Gunnison paramedic, or you're in Tanzania on a cool internship from COROM. You're all special, and we're all come from the same DNA.
Fantastic advice. CJ Malcolm, thanks for joining me on this podcast. It was fantastic to speak with you, and I look forward to our next talk.
Oh, thank you so much, sir. It's been a true honor.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.